You know, one of the great challenges of the next decade, 2, 3 decades is healthcare. We've sort of set the table for some of the developments that will certainly change our longevity. We've looked at some of the breakthroughs that are coming both in computing power, the ability of folks to use big data to help us understand healthcare better. We've looked over the past 8 years at this conference every year at healthcare, and this is no different. We've assembled 4 of the leading minds in healthcare in a panel we call Innovations in Healthcare. And before we bring our panelists on stage, let me invite you to turn your attention to the video screens and watch this introductory video from our partners at Nova.
Nicholas Volker struggled with a condition that ate holes in his intestines. His illness was traced to a gene on chromosome X called XIAP.
We found one single letter change in this gene, XIAP. Anybody who would have had this particular variation would die.
That's for your birthday. Shall we open it?
But a transplant, giving him a donor's immune system without the misspelling, appears to have saved him.
Ask the question, how many PhDs does it take to assemble Green Lantern?
We're entering an era of unprecedented self-knowledge where we can begin to intervene to take control of our own future.
You can't talk about information separate from health. How you feel is information, how you respond to a drug is information, your genetic code is information. What's really happening is we're going to start collecting it, we're going to start seeing it, we're going to start interpreting it. We're beginning the age of collecting information from sensors that are cheap and ubiquitous, that we can process continuously, and we can actually start knowing things.
My name is Watson.
For the first time in history, a computer will compete in the ultimate brain game.
Is Jeopardy!
Let's play Jeopardy! 4-letter word for the iron fitting on the hoof of a horse or a card dealing box in a casino. Watson.
What is shoe?
You are right. You get to pick. Watson.
Who is Isaac Newton?
You are right.
Who is C.S. Lewis?
Yes.
What is guitar?
Right. Over to Ken Jennings now. And we find who is Stoker? I, for one, welcome our new computer overlord.
There's a bunch of information, new diagnosis, new treatment options, new discoveries. Can anybody keep that all in their head all at once?
A machine that could access and organize all that information could help doctors analyze symptoms and wade through piles of medical journals.
It changes the paradigm in which we work with computers. That's the vision.
Ladies and gentlemen, please welcome to our stage the panelists for Innovations in Healthcare. A warm round of applause, please. Our first panel member, back for a second year in a row, is Dr. Paul Rothman. He's the CEO of Johns Hopkins Medicine and Dean of the Medical Faculty at Johns Hopkins Medicine, which is the number 3 ranked hospital in the country and the largest research hospital in the United States. Dr. Keith Stewart is also with us today. Dr. Stewart is director of the Mayo Clinic Center for Individualized Medicine. Mayo Clinic is the number 1 ranked hospital in the country. Dr. Yan Chao is the founder, Chief Innovation Officer, and Director of Kaiser Permanente Information Technologies Innovation and Advanced Technology Group. Alan Russell, who founded the McGowan Institute for Regenerative Medicine at the University of Pittsburgh, is also the founder and director of the Disruptive Health Technology Institute at Carnegie Mellon in Pittsburgh. We regret that Dr. Q. Rhee cannot be here today. He had a family medical issue that arose overnight. Our panel moderator today is Paula Apsell, Senior Executive Producer of Nova. Paula is a veteran Imagine Solutions participant, and we're glad you're back this year, and you are on. Take it away, Paula.
Thank you very much, Tyler. I'm really delighted to be back and honored to share the stage with such an eminent group of healthcare leaders. Now, innovations in healthcare are often called disruptors. That's a term that's used a lot in the tech world, where overturning or disrupting the status quo is the aim. In other contexts, disruption is usually seen as a negative. But what we're here to talk about today is positive change, making the healthcare industry work better for patients, doctors, and even insurance companies. So how is the emergence of new technology and new business models going to affect the quality, cost, and access to healthcare? And most important, how will it affect and impact our own experience as patients? So we have a fantastic panel and not very much time. So I'd like to start by asking each of our panelists to speak for about 4 or 5 minutes about what they each see as the key innovations and disruptors that will affect healthcare in about the next 5 years and how they will affect both patients and doctors alike. So, Dr. Rothman, Paul, let's start with you. From where you sit running one of the nation's most highly regarded healthcare systems and medical schools, what do you see as the most promising innovations in healthcare, and how will they make a difference?
Well, thanks, Paula. When you think about the innovations in healthcare in the next decade or so, I think they're going to be focused on a value proposition for patients and their families. So the idea is value is a combination of the quality of healthcare and the cost of healthcare. And I think many of us are trying to develop technologies that address one, if not both, of those issues. When you think about it, there are a lot of things you can do in terms of quality and safety of patients that I think are going to harness new technologies to really change the way we treat patients. And we could all give examples at our institutions of things that are addressing that issue. For us, one of the new things we're beginning this year is to address an issue of diagnostic errors. So the report from the Institute of Medicine that came out last year that demonstrated if you look at people who die in this country, 10% or so were misdiagnosed. The data suggests that if you look at patients visiting outpatient healthcare in this country now, up to 5% of them are carrying a misdiagnosis. If you think about the cost to our patients and to their care, that's a tremendous cost. So we're trying to think of innovative ways to address that question. We're going to be harnessing technology. I think Watson would be a great way to sort of help our diagnostic abilities. Things like, I'll give you an example. So strokes are often misdiagnosed in emergency rooms. And one type of stroke, called a vestibular stroke, can be diagnosed by looking at eye movements of patients. And so we have to teach people to do that, and as anything that we based on humans, there's human error involved. So we're working with a type of Google Glass to try to look at those eye movements to see if we can use technology to better diagnose strokes. Those are the sort of things that we're thinking about in terms of decreasing diagnostic errors and improving healthcare. I think the biggest area that you're going to hear, I think, from several of the panelists today is this idea of precision medicine or individualized health. The ability to say, we may think there's a disease called asthma, but in fact, within the diagnosis of asthma, there are probably many diseases in that, and maybe for every individual, there's certainly a type of asthma that that person has, given their genetics, given their environment, that would be important for their care. So although you heard President Obama in his precision medicine talk about this, and many of us are focused on this, I'll just read you a quote about it that might interest you, and it says, "The variability is the law of life, and there's no two faces are the same, no two bodies are alike, and no two individuals react alike and behave alike under abnormal conditions which we know as disease." So that's a pretty good summary, but that quote comes from 1889, and that's William Osler, who helped one of the founders of Johns Hopkins Medicine. He was a wonderful doctor. So this idea of individualized medicine or precision medicine goes back over almost 130 years. The difference today is two really revolutions in technology, one of which is the ability to precisely measure things on very small amounts of sample. So you hear about our genomes, you'll hear about the ability we can measure all the proteins in our serum, all the metabolites in our serum. Our imaging is unbelievable. So this breakthrough in what we'll call measurement, the ability to measure patients at a level we never did before, really is important and allows us to really think of the individual patient at a level we never did before. In addition, the other thing you hear about today is big data. So we now have electronic medical records. We have huge amounts of information. So the combination of taking that big data and the science of data that you heard about today with Moore's Law, 1 trillion times what it was in 1965, add that to all the data we're now generating, all the new measures we're going to have, and we're going to much better be able to target our medicines precisely to the patient. I think those would be really, Paula, innovative things you're going to see in the next several years.
Thank you. You have all of my notes. You just said beautifully, so thank you very much. Dr. Chow, let's go to you, because I'd really like to hear your perspective as the former Chief Innovation Officer at the huge healthcare system Kaiser Permanente, a physician and an IT expert. So the U.S., despite all we spend on healthcare, much more than all other countries, only has middle-of-the-road results compared to other countries. So what do you think are the key innovations in technology, policy, and reimbursement that will bring about better outcomes for more patients?
Thank you, Paula. When I was at Kaiser, I was the director of the innovation group, which looked at thousands of technologies coming to us in the next 10 years or so in healthcare. But what we quickly realized is that the real changes in healthcare are actually with policy and with decisions about economics as opposed to technology-driven. But given that, I do have to say that technology has a lot to do with it. Healthcare, as you probably surmise, is one of the most conservative, risk-averse industries in the world, one of the most complex industries. And so what we found is that in the last 8 years or so, the industry has really opened up to a lot of innovation. And so the question is why? Why now? And I think one of the main drivers of that is that we are moving from a model for fee-for-service, which is paying for activity, to value-based payment, which is paying for results. That's a fundamental change in medicine. And how is that possible? Why wasn't it possible before? Well, in the past, I think payers and regulators really only had very limited data to look at. They looked at claims data, pharmacy data, to look at maybe who was committing fraud, things like that, very gross kind of investigations. But two things have happened in the last decade that have really changed that. One is the advent of the electronic health record. That record, that EHR, was really accelerated by the Affordable Care Act, which had both a carrot and a stick. And because of that, in the last 8 years or so, you've seen adoption from 15% to 75% of the market now. So a lot of physicians, a lot of health systems now use electronic health records. What that does is it gives visibility into every interaction that the patient has with the healthcare system. And a kind of visibility in a digital form that can be analyzed, that can be looked at. So for the first time, because the EHR actually is a data collector, if you think about it, it collects data to the nth degree. So now it allows people to look at this data for quality, for outcomes, for compliance, for surveillance, for a lot of things that are yet to be determined. But the availability of that data is the first step. The second factor is that I would say in the last 5 years at Kaiser, we saw the advent of many, many different domains, not directly related to healthcare, but now starting to encroach in healthcare. Telemedicine has always been there. Mobile apps, analytics, augmented reality, virtual reality, robotics, social media, a whole bunch of areas that are now very interested in healthcare because healthcare is now 1/6 of the GDP. So because of that, you're now getting a lot of visibility into the life of the patient outside the healthcare system. So now we see granularity and also a broad view of people as they behave in vivo, in real life, as well as their parameters when they come into the healthcare system. And what this allowed payers and regulators to do is to get a much finer grained view on performance of providers, on quality, on compliance, on fraud, on a lot of things. And that's allowing the design of new processes and structures, such as the accountable care organizations, where the providers are taking some of the financial risk of providing care. They keep some of the savings so they can deliver quality at a certain level. They pay out of pocket if they spend too much. So they've taken some of the risks, and that allows allows the ultimate payer to control costs. What this has done is it's now opened the door for innovation, because people need to understand how to use technology to create sort of value-driven, outcomes-driven kind of care systems. And I think that's a huge change. That's a fundamental change. And that change is going to be happening as people look for these new technologies. And it's going to be a very interesting 10 years.
That's right. And this, what you've said, raises many questions, especially how doctors will like this being judged on outcomes that they can't quite control. But we can go back to that later. In the meantime, Dr. Russell, I'd like to go to you because you head up something called the Disruptive Health Technology Institute at Carnegie Mellon University. So you must really be a troublemaker. Now, what does that really mean? And what do you see as the most disruptive yet promising changes coming along? And what difference are they going to make to the people sitting in this room?
So thank you. It is fun to be called disruptive because now it's on my business card. I can feel much more comfortable about being that troublemaker. Disruption is generally recognized as a technology that brings three things to bear on a market. The first is that something is cheaper. The second is that it's better, and the third is that it increases accessibility. And it does all of those at the same time. So for instance, we heard a little bit about Uber this morning. If you think about your cell phone and so many other technologies that you know have created immense change in their own marketplaces, they're usually things that are cheaper, better, and create more accessibility to people who are in need of that market. If you think about healthcare and ask yourself the question, so what's been disruptive in healthcare in the last 100 years? What you find is that people like us have been getting together on panels for years and years and years and talking about, as we've just heard, the exciting future that will come, and yet it remains in the future in terms of disruption, because almost nothing has been cheaper and better and increased accessibility at the same time. It's usually been one or the other. And there's been great advances that are phenomenally exciting that we all get very excited about, but very rare that the three come together. We could do a 20-second test, and you might come up with two or three that were unchallengeable, like ultrasound and vaccines, and then you might begin to get stuck, and my colleagues here are quickly thinking of different things that might fit. So what we decided to do at Carnegie Mellon in collaboration with Highmark, one of the biggest insurance companies, is decide to use data to say where is care thought to be really good, but maybe could be really improved with new technology, and put the boundary conditions on asking great scientists and engineers to invent that future, where we ask them to invent a future that has a cost story, a quality story, and an accessibility story. An example that maybe we'll throw out as part of answering your question would be colonoscopies, a nice topic to talk about right before lunch. So, and there's a lot of gray hair in the room. I'm guessing that quite a few colonoscopies have been done.
Yes, and we all enjoy them very much.
I'm sure you do. And now you'll enjoy them even more. So it turns out that if you have an interest in colon cancer and reducing the rate of colon cancer, colonoscopies are fabulous things because you can go in, you can find a precancerous lesion, a polyp, you can cut it out and cure cancer because you can't get cancer of the colon without going through that stage. So it's really a treatment. It's not really just a diagnostic test, it's a treatment and a cure. But if you go to the data in insurance companies like ours and you say, how many people that got a colon cancer diagnosis had a clean colonoscopy within the last 3 years? The answer is surprising. It's about 20 to 30% had a clean colonoscopy, which means that during that colonoscopy, someone missed the polyp, right? So, and that's not surprising because it's actually quite difficult to do a good colonoscopy. If you've done 10 in the day, at the end of the day, you might not be as good as at the beginning of the day. So we went out to the engineers and the scientists at Carnegie Mellon and beyond, and we said, look, here's a problem. There's an outstanding procedure that can cure colon cancer, but it fails 20 to 30% of the time to do what you hope it would do. Can anyone think of a way to make that better? Because we're spending just Highmark $300, $400 million a year paying for this, and patients need it. And the answer is that someone was developing software for drones to detect improvised explosive devices, said, I know how to do that. I'll take my technology and I'll take the video output from a colonoscope and I'll write software that will tell a doctor whether the picture is too blurry or just right to be able to detect a polyp. And I'll have a red light and a green light. And within the space of 1.5 years, they're now testing that in a clinical trial to see whether, in fact, it really works. But what we're trying to do is take data and problems, align them, and then ask engineers and scientists not to try and sell us things that they've come up with, but try and sell us things that we want and deliver disruptive health technology.
I can't imagine anything worse than having to go through the colonoscopy and the prep and having a cancerous polyp missed. That would be a huge drag, to say the least. Anyway, Dr. Stewart, let's move on to you. At the Mayo Clinic, you are sequencing the DNA of all your patients. Why you're doing this, what benefits will it have, and what are the costs of that? And is this, in your view, an innovation that all of us should be having?
Well, thank you, Paula. First of all, I'm trying to get over the vision of a drone inside my colon. So.
Yeah.
You've heard from the first two speakers particularly about the need to create value and to be paid for value care in healthcare. And that means really, it means less testing, more accurate diagnosis, and using the right drug at the right time for the right person. And one way we think that we can achieve that, one technology which was alluded to by the first speaker, is the power of the human genome. And I'd like to start with my own story, which is last October, I had my whole genome sequenced. I didn't tell my wife, who's in the audience here, so it was ethically a little bit dubious, but I went ahead. And what I learned was, what they told me that day was I was a carrier of 4 diseases. For anybody who cares, they were galactosemia, spinal muscular atrophy, hemochromatosis, and Niemann-Pick disease. None of which have ever appeared in my family ever, as far as I can tell. They also told me that I should be very careful when I take tricyclic antidepressants or statins to lower my cholesterol. And they told me if I ever took the blood thinner Coumadin, which some of you in the room I'm sure are on, I would need a higher dose than the average person. And my first sense when I got that information back was a little bit of deflation. I thought, with all this hype and news, that's all you're going to tell me, that there are 3 drugs I should worry about, that there are diseases I carry that have never been seen in my family. What's the big deal about that? But as I sat and digested that information as the day went on and thought about it more, I thought what was important in the exercise was not what was positive, it was what was negative. What I had been told that day was I had no increased risk for cancer running in my genome for the known cancer-causing genes. I had no increased risk of Alzheimer's or Parkinson's disease. If I ever had a blood clot, you wouldn't need to test me again to see if that was something that ran in my family. It was already done. And for 100 years, if I was lucky to live that long, that information would not change. I would always have it. And it would inform my family. It would inform all 3 of my children about what genes they carry. And maybe they'd want to have their partner tested, which is a whole interesting spectrum of things that we might get into in the future. So what that means is, in my own case, I think I lowered the cost of my future health care. It means that you will need to test me less often. It means that the diagnosis may be more precise on occasion. And it means that I have a better clue what drugs I should take and should not take. Now you amplify that to everybody in the room here and to the 100,000 new patients we see each year at Mayo Clinic, and to the millions of Americans who could have this done. And you start to see how I think we can transform and provide better value care. And if Paula will permit me, I'd like to just ask the audience a question, which is, how many of you in the room would pay $200 to have your genome sequenced? How many would pay $500? Okay, about the same. How many would pay $1,000 to have their genome sequenced? This is because you're an affluent crowd. Usually the room is empty at that point. The cost to have your genome sequenced at Mayo Clinic today is still $9,500, which I suspect if I asked you how many would pay that, very few of you would raise your hand. So our challenge is to go from sequencing a few hundred patients a year to 100,000 patients a year at a cost that people are willing to pay for, or insurance companies are willing to pay for. And we think that's probably around the $500 mark. So thank you.
So unfortunately, Dr. Rhee from IBM couldn't be with us today, but I think I'll throw the question out to the panel. We saw the computer Watson playing Jeopardy and beating champions like Ken Jennings in the clip. But games are one thing, healthcare is another. How much will artificial intelligence and the improvements in computer technology in the future affect healthcare? Is Watson my next doctor?
So I'd maybe like to start, if you just flip back to Juan's great talk earlier this morning, and you think about these big changes in businesses. I already mentioned Uber, the biggest taxi company in the world, has no cars. Airbnb, the biggest hotel company in the world, has no hotels. And you can keep going down the list. So I think the idea behind computational medicine, in addition to computers helping doctors, is that maybe one day there would be hospitals with no doctors, doctors with no hospitals, and treatments with no doctors. Doctorless medicine is a potential of that kind of technology. Machine learning, artificial intelligence are now being directed at how to help doctors. And Vino Kostler, the well-known venture capitalist, has said that 85% of what's being done by doctors today can be improved by the year 2020 by computers. We would all argue probably about what the percentage is, but there will be a big impact of artificial intelligence. And it reminds me, just maybe a decade or so ago, a well-known economist at MIT was being asked about driverless cars, and said the famous words that, there would be no driverless cars in the foreseeable future because it was just too difficult to imagine a set of rules that could be engineered that would self-drive a car. Apparently the big problem was left-hand turns. And it turns out that now we have them. I think that we're right at the beginning of a huge impact of computational power directed towards healthcare. There's a way to go. There'll be many people that will say that future is a long way off, but I think it may surprise us how quickly it comes, just like it did with driverless cars.
So Dr. Reed told me that Watson can read 80 million pages of medical journals and medical literature a second, which is really kind of amazing. But do you think that doctors will welcome this as a valuable assistant, or do you think that they will feel that it's a substitution for their judgment and something else that they'll be judged by the insurance companies for? Did their decision and diagnostic decision agree with Watson's?
Well, while you were looking at me, I was looking at some doctors. And maybe they should answer.
You go ahead.
So, when I think of technology in Watson, I think of really a great asset to healthcare. I think of a technology that will get a lot of unneeded variation out of healthcare. I think of a technology that will get errors out of healthcare. So I think it's wonderful. I think physicians are embracing it. But I can't believe that the physician's going to replace, at least, maybe it's because I have the gray hair in the room, but it's not going to replace physicians in that I think physicians are going to their use is going to be more on keeping the needed variation in healthcare, reading what Watson or someone tells you about the patient, and then looking at the patient and understanding if that makes sense for this patient, because I don't think it may be able to diagnose well, but it won't see the husband and the wife together in the room and understand a social dynamic. So I think it'll be really important as an asset to use, but will hopefully not replace physicians. And also the touching of hands. I mean, let's not, unless, well, maybe Watson will get hands and will touch, but at least in the near term, I think the touching of hands, the laying on hands, the support that a physician can provide to a patient, at least to date, I don't think Watson can replace, but maybe I'm wrong.
Yeah, I think it's a really interesting question about who our doctor will be in the future. Couple of data points. One is that studies have been done that show that computers at diagnosing the disease you have when you walk into an emergency room can be as good or better than an emergency room doctor. That's one data point. The second data point is that Kaiser tried artificial intelligence decision support, and the problem with that is that you don't know how it came to the decision. That's the black box issue. And if you don't know how it came to that decision, even though you know it's very fast computer, very high quality algorithms, you still have to trust your life to that. And so many physicians will not do that if they don't understand how you got there. I think that's one of the major issues. And for physicians, the third data point is that I was discussing this last time with somebody. There was another study done where for epidemiologists, they figured out that you need 22 hours of research or reading a day to keep up with your field. So essentially the bottom line is you can't keep up with your field no matter what specialty you're in. You can't. There's no way that the information on medical literature is just going like this. You can't keep up. So what is the role of a physician in the future? It's not to be a know-it-all. You cannot be. So are you the patient advocate? Are you the translator? Are you the person, the face that they trust? What is the role? And I think that brings up really interesting issues, because I think, even in my alma mater, I don't think they're teaching physicians like that. I think this brings a lot of interesting issues.
So here's something that's interesting food for thought when you think of the kind of human technology interaction. I've heard that with driverless cars, almost all of the problems are caused when the human driver intervenes. That's much less safe than having just the driverless car operate alone. I mean, we don't want to believe that, but that actually seems to be the information that's coming out of Google now. Going to a slightly different topic, we've talked a lot about technology, big data, genomics, artificial intelligence, liquid biopsies, but we also hear a lot about the necessity for cost control. American medicine is always criticized for being much too reliant on technology. So how can this be reversed by more technology in terms of cost?
I think that's for you there, Paul.
No, Kaiser's
They're each passing it to each other.
Right.
This is the hot cake of this discussion, cost.
It's interesting because I used to work at Kaiser. I retired from Kaiser. Kaiser is one of the largest integrated care delivery systems in the United States, along with the VA and a couple other big systems. And so in those systems, the provider and the payer and the physicians are all in the same system. They negotiate internally, but they go to market as one entity. So in those kind of systems, it's always been the case that Kaiser's always been trying to improve quality, and also trying to improve affordability, because it's taking the risk for the cost. And it's still working on it. It's not perfect. But I think technology is going to allow sort of the amplification of certain kinds of tasks that we do in medicine over and over. And it's going to allow us perhaps to send those tasks down the ladder, if you will, to lower cost providers. So technology, along with rules and along with physician support, can allow many of the mundane things that physicians do to be offloaded. And that's going to allow physicians to be a lot more productive. So is that good medicine? Well, as a pediatrician, When I have patients come in at Kaiser, they get seen by a nurse because they just do the throat swab for strep throat. And I don't have to do that, although they lose the touch with the physician. So it's a trade-off. So I think in the future, as people get older and the diseases get more complex and we get chronic conditions, the cost is going to drive organizations to do something like that.
You know, I was going to comment value, but before I do, one of your comments made me think that if we ask our physicians what's their biggest dissatisfier in their day, it's the clerical burden of the technology we have to deal with, and it's contributing to physician burnout, less time spent with patients because they're spending time looking at a computer screen and ordering billing and ordering their next diagnostic test. So I guess I'd challenge you with that comment. That's going to make our life more efficient.
Right.
Maybe eventually.
Right. I think a lot of the systems are written in I would say 30 years ago. And so it was written by programmers. So the physicians are thought to be like programmers where you sit in front of a keyboard. And I know one of my colleagues, most of my colleagues really decry that. They hate that. You know, they hate having to turn to the computer to talk to the computer and then turn to the patient, talk to the patient. Very different modalities. But I do know some physicians that will put the screen between themselves and the patient, so they'll peer over the top, and the patient goes like, "Doctor, are you there?" So there's some physicians that are like that. But for most physicians, I think the ideal interface will be when you combine speech recognition with video image recognition. So the encounter is just like a human encounter. The computer gets a lot smarter at interpreting that, as opposed to the physician having to translate for the computer. I think that's coming.
Paul, I'd like you to speak a little bit about costs, because as someone who sits in control of a whole healthcare system and a medical school, I bet you think about it a lot.
Well, I think we do it. My initial comments were about the value proposition, and I think we're all focused on getting healthcare costs. You know, the Kaiser model, you know, where you don't strictly do a fee-for-service but have a capitated payment model, I think is going to be important in driving down costs as you align incentives. And I'm going to ask my colleagues to talk about, I just want to make one point that I always think about. When you think about cost, also think about, there's a book that I read when I was in high school called Lives of a Cell by Lewis Thomas. And in that book he talked about, and this is a long time ago, but he talked about how as we increasingly understand a disease, the cost of treating that disease goes down. So he talked about diseases where we just do supportive therapy. I'd argue Alzheimer's today would be an example where it's very costly to us. Then he described diseases that we utilize halfway technologies to treat, in which we sort of know the disease, we could do some targeted therapies. Asthma would be a good example today. And then he said there are diseases where we can develop what he said is definitive technology. And for people, and one would be in a whole sorts of things that we use vaccination for, where we don't see the disease anymore. Think of polio. Think about the cost of polio in the 40s or 50s, and think about the cost of polio today in this country. So in fact, although we have to do a lot to get costs out of our healthcare system, we can't afford 17, 18, probably 20% of our GDP in the next several years going to healthcare. We have to get efficient. We have to drive costs out. The true costs will come out when we understand disease states, and where basic research allows us to understand what causes the disease, and we can develop the definitive technologies to cure the disease. So I think about all that when I think about cost, but we do have to get our present health care costs down.
So how much then is it a concern that healthcare research spending and the money devoted to research seems to be either level or going down?
So, you know, go ahead. I'll let you do it.
Well, you know, I think one of the speakers earlier this morning challenged us to think of companies that have been spun off in both the United States and Europe. And if you ask that same question about the biotechnology industry, you would get the same answer. This is a hotbed of biotechnology here in the United States. That's why we have the best cancer treatments in the world first, before they disseminate. And in Europe, I think you'll find that innovation and sort of fearless culture in technology is less prominent. And that's in large part because of the funding that goes to research in this country from the National Institute of Health, from foundations, from the pharmaceutical industry. So I think it's critical that for our future that we continue to sustain that and even expand it.
Now, we often hear about promising technologies and treatments, but insurance companies don't want to pay for them. And that seems to be a real conflict, and I bet a lot of people in this room have experienced this. So, Alan, you work at putting together providers and insurance companies so that they don't fight so much and have a more cooperative relationship. Is this, can you tell us a little bit about this, and is this a reality for our healthcare system in the future?
Yeah, so it's troublemaking on steroids. It is true that a lot of times companies get their products approved by the FDA, and then they assume that because the FDA has said something is safe, and the FDA believes maybe it even works, they assume that when they go to an insurance company should say, yep, we'll pay for that. And the doctors are waiting for them to say that they'll pay for it because they've been involved in helping to invent it. And insurance companies often turn around and say, actually, we think that's still experimental and we won't pay for it. And then a fight begins. And it really is a nasty fight. And at many insurance companies, most of their days are spent looking at new technologies that promise to save money in the future, that don't. And they have a lot of experience of seeing that, so it makes things difficult. So one of the things that we are doing is creating a pool of resources that will essentially bring in a technology that is experimental, and whilst it's being clinically tested, have the resources of an insurance company, but not the medical policy change, have the resources of the insurance company actually pay for the clinical trial in our own system. Both testing the cost story and the quality story and the clinical story all at the same time, so that we can shrink the necessary time that it takes for something that deserves to be used in patients to get there. I think it's, what all of you hope that we do is come true with our responsibility to identify, invent, investigate, and implement the right technology for the right patient at the right time, place, and cost. And in doing that, it's very important that every part of the healthcare equation works together on this technology piece. What's happened for the last 20, 30 years is that providers, doctors, and hospitals have worked together with innovative companies to bring new ideas to the marketplace. But insurance companies haven't been part of that calculus until the very end. And I think, and Highmark, Blue Cross Blue Shield thinks, that the insurance companies should be at the table before the technology is invented, helping to set the agenda, helping to explain what they're looking for. And maybe I'll end by just reminding everybody that if we're healthy, our insurance company makes more money. They want us to be healthy. Our doctors want us to be healthy too, but they actually make less money if we're healthy, which is a kind of interesting switch and conundrum than we often think about. So if we can get insurance companies to be not just referees at a football game, but actually in there, playing the game and helping, I think we could really shrink the time for new technologies to get to help.
So do you see this as a trend that will really, this kind of uniting of providers and insurance companies and technology, as a trend that will really be coming, we'll see more and more in the next 5 years?
Yeah, so I'm not sure that the big business trend is necessarily a good thing, but one of the things that the Accountable Care Act created was almost a need for insurance companies to consolidate into very large companies, to start including payer-provider components, so that the industry is really coming together in a very different way than before. So I do think that what I'm talking about might actually be one of the good outcomes that comes from that, because it will now be possible that insurance companies can see very good reasons to be at the heart of innovation and at the heart of driving health forward.
So just to extend, so Alan's point is, what happened in the Affordable Care Act, we saw a huge consolidation of both delivery systems, hospitals becoming big systems, insurance companies getting bigger. What I think you're going to see, and it has to do with what Alan talked about in terms of the misalignment of incentives, because, as he said, if people get healthy, doctors would make less money, is what we and many others are doing, what Allegheny and Highmark are doing, is the insurance company and the delivery system merging into one entity. And you're seeing that Kaiser was the paradigm of that, so that you have aligned incentives, so that the entire system is benefited by having people get healthy and using the system less. So I think you're going to see increasing amounts of that.
I just have to push back on it for a second, because I personally was part of a managed care system years ago in Boston, the Harvard Community Health Care System, which started out wonderfully. But then, and I think many people agreed with this, they started to really undertreat because their incentive was to save money, and it was actually very frightening. And I know of many cases. One of my colleagues at Nova had Rocky Mountain spotted fever, and they would not send her to the hospital for a long time, and then she was very sick. So is one of the downsides of this that the providers and the insurance companies could ally themselves against the patient and undertreat, because we all know follow the money, very important.
I would argue the issue is not so much under treatment as treating appropriately and correctly. And so at Mayo Clinic, all the physicians are salaried, so we have no incentive to operate when it's not necessary, because we don't get paid more for doing that. So we are generally viewed as being very conservative when it comes to spine surgery, for example, because we turn people away. But we think that's a good thing. We think that avoids unnecessary surgery. It lowers the cost of healthcare because we're not doing unnecessary surgery. And one thing I know that my colleagues at Mayo are working on very hard is this notion of being paid for value of care, not for the number of procedures you do, which is the way most physicians are reimbursed today. And we think that we may be a little bit more expensive at the front end, but over the continuum, we're going to save the system money by doing it right the first time. And I think Johns Hopkins, I'm sure, shares that value with us. Kaiser Permanente shares that value with us. And so the whole payment system for physicians is actually somewhat flawed, because the incentive is to do more procedures, prescribe more medication, and many of which are probably not necessary. Do more diagnostic testing.
Well, that raises a question that Dr. Chow was talking about, this value-based reimbursement, getting reimbursed on the basis of outcomes. But the doctor can't control whether patients take care of themselves, whether they follow their diet if they're diabetics, whether they're overweight, whether they get exercise. Is that really fair to the physician and other healthcare professionals?
Right. Well, I think the real challenge has always been the behavior of patients. I'm a patient, and you're a patient. Patients just don't act in their best interest all the time, and a lot of it is for reasons that the physician may not know anything about or be aware of. So I think that there's a couple of trends today that are affecting that. One is that the Affordable Care Act has really started to move patients to a self-responsibility, which is a huge thing. It's really never been happening before. And before you go to the doctor is responsible for everything, and therefore gets the authority position. But now patients have health insurance exchanges they go to. They have to choose the health plan. They have to figure out with limited information what's the best choice for them. So they're starting to look, they're starting to Google things. You start to see companies selling directly to patients equipment that used to be for physicians. You think about that, what's happening? A semi-professional market is emerging. Patients now have to take responsibility. That creates opportunity, but it also creates a lot of complexity for the physician. Because guess what? If things don't work out, guess who they sue? They're going to sue the doctor, even though the doctor didn't know anything about it. On the other side, because I mentioned about data, now we know a lot more about what patients actually do. And so I'll tell a story. I have a good friend who's an endocrinologist in South San Francisco. She's Filipino. She takes care of a large Filipino diabetic population. And it's always been a real challenge for her because they never listen. It seems like they would never, and with diabetes, you have to do a lot. You have to track your sugar, your urine, all kinds of things. They never did that. So she finally was thinking about that, and she thought, you know, I'll try this, because she knew Filipinos are very much into family. So she would tell her patients, don't you want to be around for your granddaughter's wedding? That did it. That did it. All of a sudden, people were starting to comply. And that compliance issue is a big issue across all of medicine. I mean, do you have to know that kind of a cultural insight to get patients to change? Well, some of the most exciting startups today are working in behavioral research, where they're actually taking the evidence base from research studies to find out what motivates people to do things. And it comes from marketing, it comes from many different domains, but I think the real payoff in medicine in the future is going to be how do you get the consumer to see the same value that physicians see and try to convince them of every day.
So I'd like to go back now to genomics, sequencing our DNA, because frankly, I was really fascinated to see how many of you raised your hands. You are much braver than I am. I would be terrified to have my genes done. I don't mind having my colors done, but my genes done is much different. So, Keith, you're doing this with all your patients at the Mayo Clinic.
We'd like to.
So, but I do have to ask the question, as sexy as this technology may be, is it really ready for prime time? Has the technology in this area outstripped our ability to interpret it and to know what to do with it? For example, if I find out at 35 years old that I have a gene that puts me at greater risk, not 100% risk, just greater risk for Alzheimer's disease, am I going to spend the rest of my life worrying about that? Is that really beneficial to me? So I'd really like to get your opinion and the rest of the panels, because this is definitely something that's coming down the pike.
So this has been a very hot area of research, and Alzheimer's is a great example. And there have been studies showing that psychologically people can get quite disturbed when they learn about a risk for Alzheimer's, including apparently some suicides. So I'll go back to my own case. When I had my genome sequenced, they ask you, would you like to know about that or not? And I confess that initially I said, no, I have no interest in knowing that. But then I changed. I scratched out, said, you know what, I'm going to learn. And I think that what was important for me was the knowledge, the idea that knowledge was power. So if I knew I was at risk, I think I would undergo some lifestyle modifications. I might not drink so much Chardonnay in the evening. I might exercise more. I think it would be a real motivator to keep my brain and cerebrovascular system healthy. But I'd also be looking at the latest research. I'd be looking for clinical trials for early diagnostics to try and help me pick it up early and intervene. And we're very close to getting therapies for Alzheimer's that will work. And I think in the next 20 years, hopefully, if that were my future, there would be something I could do about it. So I would rather know personally. But there are issues, and I think it's right. It doesn't mean you're for sure going to get it, so you could anxiety yourself to death thinking about it.
What do the rest of you think?
I agree completely with Keith. I think that
that's the first time an Englishman ever agreed with a Scotsman ever. By the way,
it's true. It's true. I take it back. I disagree with every word. So, but there's one addition that I'd like to suggest, and maybe it's a little bit controversial. I think we need to dramatically increase teaching statistics in school and effectively teaching statistics, because at the heart of whether you are afraid or whether you really want to know that is an understanding of statistics and you know what it means when you read something in terms of how sure you are or not sure. So today, if you were to ask the general population what their level of understanding of statistics is and try and relate that to how prepared the population is for this kind of information, I think there's a gap. So I think there's a responsibility to bring both things around at the same time.
So I agree. So I think getting the information is going to be important, but you need to be counseled. And today, since not many in the room probably have had a course in modern genetics, I think the important thing is to make sure you have the right counseling with that information, because you can get your genes back and say you're at a 3 times greater risk to get some disease, but the risk is 1 in a million versus 3 in a million, so the odds of you getting it are very, very low, but you'll pontificate and worry about the fact that your risk is 3 times. So I think really robust genetic counseling can really help people understand their genomes.
And also I think the other issue that many people don't think about is, will it affect your insurance premium? And in fact, not just your insurance premium, the insurance premium of all your descendants. I think that's a real big issue. I think people just need to understand that.
Yes.
Because once you know it, you can't put it back.
So I think there's some laws for that, but
There are
they
some
don't
laws,
cover long-term care insurance.
So there's laws that prevent you from being discriminated against in the workplace. There's no laws against your life insurance company using that information, and that puts people off. But I've thought about that a lot too. And if I'm a life insurance company, yes, if I have a cancer risk, I might want to charge that person a higher premium. But on the other hand, it's better to know they have it than not know they have it, right? So if I'm an insurance company, I go, okay, you're a cancer risk, you need to be screened every year or your premiums are going to increase. And we can lower your costs. And in a case like mine, where I have no cancer risk, if I'm a life insurance company, that's good news. I can probably charge Keith a lower premium if anybody's out there listening. So, so I actually think it's probably not the big bogeyman that people are so worried about. This issue of the traits and the statistics, I wanted to tell the audience, if you have grandchildren or children, there is a huge shortage of genetic counselors. You know, if you start thinking about me telling you we want to sequence all the genomes of 100,000 people at Mayo Clinic and millions of people across the country, and there's almost no medical geneticists in the country, and there's almost no genetic counselors, that's a big job growth industry right there. And the other one is bioinformatics. So, you know, is the technology outpacing our ability to interpret it? It is. When I had my genome sequenced and given back to me, I was told there were 600 mutations in genes that nobody in the world could tell me what they mean. And if we sequence the genome of a cancer patient, it takes a PhD 2 days to sit and analyze it now. So the automation that's required, the scale of, and things like Watson will help there, the scale of medical genetic counseling, medical geneticists that we will need and the number of bioinformaticians they will need going forward is immense.
So I think the focus of this panel is around a kind of a holy trinity of quality, cost, and access. And I'd like to go to the last, access, because healthcare in this country is highly variable, both in terms of quality and access. And as I mentioned before, outcomes are often seen as kind of middle of the road when compared to other countries that spend a lot less on healthcare than we do. So how will these innovations that we've talked about move the needle in terms of equity and in terms of extending the benefits of our wonderful healthcare system to everyone?
So the silence.
Yeah.
I think that if you think about healthcare, doctors do an incredible job, and I think we all understand that. I think healthcare providers, nurses, and the whole team do an incredible job. Maybe the part that you're pointing to a little bit is that patients aren't quite as good. There's a lot of room for patient sort of compliance with both how they take care of themselves before they get sick and once they become sick that can really be improved. And one of the most exciting aspects of new technology, of new things that are being developed, are the tools that will empower patients to take better care of themselves before they're sick and after they're sick. So for instance, heart failure patients, it's quite well known that a heart failure patient, of the folks that get a prescription when they leave the doctor, about 20% of them don't fill a prescription. These are quite sick patients. An even greater percentage don't get it refilled, and an even greater percentage don't take it, so that the majority of patients who are being treated by a doctor don't, you know, for pretty serious disease in that case, for whatever reason aren't able to process it. Technology can help on both ends of that equation, can help them adhere to a plan, and can couple in with cost and many other areas. So I think that, you know, our smartphones, our tablets really will have a high impact on how people interact with the healthcare system and take better care of themselves.
But what about the millions of people who don't really have access to the healthcare system and don't have access to the technology and the new systems that we've discussed? Paul, do you want to take that?
So when you think about access in this country, there's obviously the Affordable Care Act, Obamacare, has increased access. Probably up to half the people who otherwise weren't able to access the system will be accessed. when Obamacare and the Affordable Care Act was heard. That still leaves wide numbers of people uninsured. You know, we always think of just the urban poor, but there's rural poor. And so one of the things technology is going to be a great benefit for is the rural poor, because, you know, what you get into, I was the dean at Iowa for 8 years, and there's a huge issue in rural medicine. And I think technology has a great role there, because a physician can't go to a town, can't stay in a town of 500 people. There just aren't enough patients for them. But nurse practitioners, physician assistants, utilizing technology and telemedicine can be in small towns and provide care in small town and rural America, which is a big part of an access issue in this country, not just because of affordability, but because of distance. So I think technology certainly has a role in providing that. The bigger question is, you know, it's really a political question and not a technology question, which is how you provide care to those people not covered by the Affordable Care Act.
Anyone else? Jan?
Yeah,
Keith?
I'd like to say that in lieu of known models for technology working with physicians, now new companies are starting to enlist others who are not traditionally part of the healthcare system. So the community, you know, the adult children, involving those kind of resources so that, and that sort of fits right along with the patient empowerment trend. So I think that that's going to actually be very important, because what happens to the patient outside the healthcare system is a lot more than what happens inside the healthcare system. The other sort of point I want to make is that in terms of public policy, what do you do with the old folks like me? What do you do with old folks? There are now developments now to help us become human 2.0, which is very interesting, because now they're saying people are going to live to 120, 150. Well, I'm not going to spend all day golfing. I don't even golf. So what am I going to do? So I think to create the value in the society, to trade off, to start bringing value back into the economy, we should start thinking about using those technologies to help aging populations create value from their experience, their skills. That's a huge thing that nobody's talking about. I think that's really important. So public policy-wise, yes, we have to take care of the ill, but let's think about going beyond that. What are we looking for in the future as a society? I think that's really important.
So we only have 3 minutes left, and I want to ask you what I think is the key question behind all the things that we've been discussing, and each of you could respond. We have this clock in front of us. We could go on for hours, I think. So the key question, will the technologies and the innovations in healthcare that we've discussed today help more of us live longer with more quality of life? And if they won't, what will? So I think that's the big question and the take-home message we'd like to hear.
I think the answer is really exciting. The answer is an absolute yes. But the way I often say it is, it's our children's children that will experience most of that benefit. It's not, which is incredibly exciting, that our grandchildren won't have to deal with some of the things that we have to deal with is phenomenal. But you know, to say, hey, in 5 years, yes, this is all going to change and everything will be fixed, you know, probably not. But the movement is already taking place, and I think the alliances that are necessary to create the kinds of shifts that you've seen in the telecommunications industry, in almost every industry except for education and healthcare, there's been huge fundamental shift. We will see that also in healthcare.
I would agree. I think that we are going to live longer. We are going to have better quality of life. But then it raises deeper questions, which is why? You know, why do we want to do that? So.
That's very Confucian.
Yes, yes.
You know, I want to leave the audience with a message. I think that medicine has never been better. It remains, since I've been in it for 30 years now, incredibly exciting always. You've heard today about genomics. We didn't talk about building new organs, which Alan is an expert in. We didn't talk about studying the microbes in your body and how they affect your health. We didn't talk about the revolution in cancer care, which is going on right today in immuno-oncology, using the immune system to battle cancer, which is phenomenally changing how we treat cancer. And all those bad, ugly drugs are going to go away in the very near future. So I think you should leave the meeting feeling confident in the healthcare system, that it's continually evolving and improving.
So I agree with my fellow panelists. This last point that Keith made, the revolution in care of cancer is something that is happening right now in this country, and you're going to see huge benefits in terms of life expectancy in this country in the next decade because of really these new breakthroughs, both in immuno-oncology, but also in the sequencing of the cancers and directed therapies for cancers. I think we're in the middle of the most exciting time in medicine, and I think people there should be very optimistic of what they're going to happen in the next 10 years in medicine.
Well, I can't believe it. We are finishing right on the button with this very optimistic note. You are fabulous panelists. Thank you all very much. You're a wonderful audience. And I'd just like to thank Pam Rosenstein and Linda Callahan from my shop, from the Nova shop, for helping to produce this session. Thank you all very much, and thank you.